is, to me, is one of the most difficult areas for a pulmonologist. First, because you need to interact with rheumatologists, and that's a pain. I mean, at least for me, it's not easy. And secondly, because you have a degree of uncertainty which is huge. So I try to figure out this presentation based on my daily clinical practice. CTD is a universe. Connective tissue disease is really a huge constellation of different patients, different disease, different definition, different categorization, different prognosis, it's very diverse, it's huge, connective tissue disease. But within connective tissue disease, you have some of these, they have respiratory symptoms. So that's an easy classification to me. As a pulmonologist, I will only care of patients with connective tissue disease and respiratory symptoms. Can be cough, can be dyspnea, can be anything, but they have to have respiratory symptoms. However, sometimes our radiologists, they take a high resolution CT scan in a patient with scleroderma. Nobody knows why. And they find chest imaging abnormalities. The patient is fine, no symptoms, normal lung function, but the CT scan is abnormal. That's a major problem. That's a major problem, because what to do with these patients? And on the other side, these are patients with non-ILD. You ask yourself, does this patient has any subtle underlying undiagnosed connective tissue disease? In particular, she's a woman, she's 55 years old with some rhino phenomenon. So the spectrum of connective tissue disease and ILD is very wide, and it goes from rheumatologists just taking high resolution CT scan in patients with established connective tissue disease to pulmonologists dealing with patients with non-ILD, and they ask themselves, does this patient have connective tissue disease? So how do we deal into these dilemmas? So I try to put some questions that, to me, as a pulmonologist, they are critical. So my patient has a connective tissue disease and chest symptoms. Why should I worry about that? Well, the patient is on treatment, the patient has a diagnosis of connective tissue disease. Why should I worry about that? This is why I should worry about that. This is cause of death in rheumatic disorders, rheumatoid arthritis, sclerodermas, lupus, myositis, Sjögren. If you go to pulmonary, you see that up to 60% of patients with scleroderma, they will die because of the lung disorder. So in other words, lung involvement is the major cause of death for patients with scleroderma. But that's also true for myositis, that's true for Sjögren. So we need to be aware that pulmonary involvement is a major cause of death in patients with rheumatoid disease. That's why when you pick by chance a patient with connective tissue disease, an abnormal high resolution CT scan, you should worry. Because it's very likely that that abnormality is going to be the cause of death in that patient. So in connective tissue disease, the presence of a chest disease is associated mainly with more respiratory symptoms. The patient gets more dyspnea. Their impaired functional status, they're less efficient in the daily life. The quality of life is lower in patients with lung involvement and connective tissue disease as compared to patients with connective tissue disease and no lung involvement. And lastly, the greater healthcare utilization. They get for high resolution CT scan, they get for 6-minute walking test, they get for lung function test, and all of that. Finally, as we have seen in the previous slide, they live shorter. So In other words, when you or your rheumatologist, they find lung involvement in connective tissue disease, there is a good reason to worry about it because of all of these reasons. The next question is the following. My patient has a connective tissue disease and respiratory signs and symptoms. What is their cause? It's not an obvious answer to this question. It's not that always the respiratory symptoms are directly related to connective tissue disease. If you look at the table, this table that has been drawn by many publications in the field, connective tissue disease and the lung, in rheumatoid arthritis, lupus, scleroderma, polymyositis, dermatomyositis, or Sjogren, in all of them, you can have infection being responsible for respiratory symptoms, and the drugs that are used to treat connective tissue disease, they can all be responsible for lung disorders. Not only, then you have the interstitium, the vasculatures, the airways, large and small, the pleura, the thoracic cage, they can all be involved in all of these diseases. So it's very clear cut that it's impossible for a rheumatologist not to deal with a pulmonologist, that it's impossible for a pulmonologist not to deal with a rheumatologist. The respiratory symptoms in connective tissue disease, they come from the lung, they can come from the heart, of course, and sometimes they come from the esophagus in patients with scleroderma. So, does it matter that the patient has CTD and symptomatic lung disease? Yes, it doesn't matter a lot. Because you see, survival is shortened in rheumatoid arthritis patients with lung involvement. Okay? So, if you look at these slides, these are patients with lung involvement in rheumatoid arthritis, and they live shorter. And these are data from the group of Kevin Brown in Denver that has been submitted, not yet published, going to be published soon, is that if you look at patients with rheumatoid arthritis ILD as compared to the RA cohort or age-matched cohort, this is a patient with rheumatoid arthritis without interstitial lung disease, and these are patients with rheumatoid arthritis and interstitial lung disease. So that's very clear cut that they live shorter. That means that you need to give to these patients a prognosis which is shorter than patients without the disease. So have we been able to target the lung disease associated with connective tissue disease? The short answer is no. We've not been able to do that. If you look to the rheumatoid arthritis associated mortality rates between 1988 and 2004, the decline was 21%. And in particular, it was 34% in men. Is reflecting that the therapies that we use for rheumatoid arthritis in general are effective. But if you look at the rheumatoid arthritis associated ILD mortality, the mortality rates, they do not decline, they increased in the same period. So this means two things. One, that our colleagues rheumatologists, they have been able to manage very well with rheumatoid arthritis in the absence of lung involvement. But when lung involvement is present, the current therapies for rheumatoid arthritis doesn't work. Not only, but the mortality actually increased over the last 20 years. And this is a reflection basically of the use of high-resolution CT scan, the prevalence of rheumatoid arthritis ILD also increased. So this is not clear-cut if this is a true increase in prevalence or it's just a better diagnosis by more use of high-resolution CT scan, but nonetheless, there are more and more patients with connective tissue disease and ILD, and these patients are not treated by the current treatment for the underlying disease. And this is very clear-cut. These are data from our group in Modena. These are our rheumatologists. The impact of ILD in scleroderma is also important. These are all scleroderma patients, and this is the survival of patients with ILD and scleroderma. That's clear-cut, that the lung is the limiting organ for the survival of these patients. So my patient has a connective tissue disease, and chest imaging is abnormal. However, no respiratory symptom. What should I do? What? PFT, wait. So the frequency of abnormality at chest high resolution CT scan in connective tissue disease is extremely high. So the point that we call these abnormalities, what does it mean? Is that a disease? Is that just something that we pick up with a very sensitive tool which is high resolution, no clinical relevance? So the point of PFT is a crucial one, but again, if you take a high resolution CT scan in the typical patient with rheumatoid arthritis, all of them will have abnormalities on CT scan. What do you do with that? This is what I'm considering doing. You need to determine the clinical significance of the finding. It's not that a report from your radiologist of reticular opacities in your patient with connective tissue disease is making you change your behavior. You need to assess the clinical significance of that finding. You need to evaluate symptoms. You need to determine the extent of abnormality, and of course, pulmonary physiology is a critical point. But gas exchange with activity is also important, and most importantly, I think, you need to follow over time. So the major point here is that if you find a patient with connective tissue disease and high resolution CT scan abnormality, do not forget about him or her. You need to follow up that patient, because in that patient, that lung involvement can be the cause of death. You know, the predictors of mortality in scleroderma are FVC and the extent of pulmonary fibrosis on chest radiogram. FVC percent predicts survival in scleroderma. So again, lung function is extremely important in this patient. And when I see patients managed by rheumatologists that don't take any lung function, I'm really worried about that, because they cannot predict the prognosis of these patients. And also high resolution CT disease extent predicts survival. This is a study from the Brompton showing very clearly that the more extensive is the involvement in high resolution CT scan, the shorter is the life expectancy for this patient. And they propose this categorization, which what we are using now in our center: high resolution CT scan extent, FVC combination, limited disease, extensive disease. At least you are able to predict the prognosis of these patients. And if you want, you may try some more aggressive therapy. If a patient has an extensive disease, he's going to die early. Why? Because we know very clear-cut that simply by assessing FVC and disease extent at high resolution CT scan, you can predict the mortality of these patients. That's very clear. Now, one of the last questions, which is critically important. My patient has interstitial lung disease. It is due to connective tissue disease? That's one of the most difficult questions in my clinical practice. which is going together with this further question: what laboratory findings suggest a connective tissue disease to a pulmonologist? None, to me. But if you deal with the rheumatologists, there are many of them. And this is extremely important and difficult area. This is a study by Ari Fisher, he works in Denver, showing that the low-level ANA titers, they are very non-specific, and they can be found in up to 25% of patients with IPF. Are they different from patients without ANA titer and IPF? Probably not. So that means that all of these testing are okay, they may be useful, but they are completely sometimes non-specific. And this is a study that has been published in 2009 against specific antibodies against rheumatoid arthritis in patients with ILD, again showing that these monoclonal, autoantibodies, they can be quite non-specific in the clinical practice of patients. One of the last questions, if you look at the high-resolution CT scan, is there anything suggesting you that this disease can be related to connective tissue disease? Yes. Yes. So these are idiopathic interstitial lung disease, a connective tissue disease related, and you see very clearly that the CT diagnosis is different. There are more NSIP in the connective vascular disease, but this again is a clinical diagnosis. When your patient, so when your radiologist, it tells you maybe it looks like an NSIP, which is a long jump, always be suspicious about an underlying connective tissue disease. You see, the imaging of NSIP is very typical, in particular when you compare that to UIP. So there is definitely more ground glass, more consolidation, more traction bronchiectasis, no honeycombing for NSIP, and that's as a suggestion for an underlying connective tissue disease. So this is idiopathic versus connective tissue disease related subtype, and you see that they are completely different in terms of survival. Anytime that there is a connective tissue disease underlying your ILD, even in the absence of treatment, the prognosis will be better than in patients with idiopathic pulmonary fibrosis. Some signs, sometimes they are overlooked by the radiologist, but you look here, pericardial effusion and pericardial thickening, they are much more frequent in patients with connective tissue disease as compared to patients with idiopathic. And this finding, which is usually overlooked, some pleural effusion, it may be very sensitive to tell you that maybe that patient is not an idiopathic, is not a typical IPF, but has some sort of underlying connective tissue disease. Of course, esophageal dilatation, in particular in patients with scleroderma, is something which is strongly suggested. So again, when you look at the high-resolution CT scan, don't look just at the parenchyma, right? You look at the pericardium, you look at the pleura, look at the esophagus, because there might be some hint that that disease is not idiopathic. So this is my last slides, and I want to try to, this is a scheme that has been proposed by Ari Fisher and Ron Dubois in the Lancet last year. When you get a patient with an interstitial pneumonia, the first thing that you have to do, look for known cause. We're talking about drugs, okay, difficult, exposure, but not connective tissue disease, but known cause. This is the first category, and you need to exclude this patient. You need to find out this patient. Then, you have no connective tissue disease features, typical, antibodies, or connective tissue lung pathologies. In this case, you are in the realm of idiopathic interstitial pneumonia, because there is nothing that you can use to tell this disease is non-idiopathic. So that means that you have to look for the physical, the extra pulmonary feature of connective tissue disease. Maybe you take a capillaroscopy, or you look for some disease, you look for the antibodies, or you look for the pathology, and when you get the pathology, your pathologist tells you, look, there is nothing suggesting a connective tissue disease, like lymphocytes or lymphoid granulomas or so on. Then you have clinically features of connective tissue disease and positive autoantibodies, very clear. You have definite CTD ILD. In this case, the therapy is the therapy of the connective tissue disease. If it's scleroderma, it's the therapy of scleroderma. If it's rheumatoid arthritis, the therapy of rheumatoid arthritis. If it's lupus, it's the therapy of lupus. Last box, which is a gray zone, of course, there is no connective tissue disease specific features, but you have positive autoantibodies. It happens very often. In this case, you have a possible connective tissue disease, ILD, and Ari Fisher is now proposing this new entity, which is a lung dominant CTD. Huh? You like it? You love it? That's very worrying. So, what is LD-CTD? Lung dominant connective tissue disease means that you have a connective tissue disease which is only in the lung. Very difficult to diagnose, and probably is a spectrum between the classical CTD-ILD and the classical idiopathic. So for the time being, the recommendation here is that when you find a patient like this, you follow the patient over time. Because many times the patient will switch this way or this way. We don't know if this ILD-CTD is an entity or it's just a transition because we pick up autoantibodies with no meaning or very early in the transition to this. But at the same time, I think it's important to recognize that with some patients, it's impossible to put them in this category or this category from the beginning, and it's much better to keep them in this mid-category and see what happens with follow-up. Thank you very much.
Thank you for this very practical presentation. We may take 2 or 3 questions if you want.
Thank you again, Professor. 2 questions. One is probably your thoughts. Do you suggest that if we collaborate with our rheumatologist, that we should get baseline high-resolution CT scans and pulmonary function tests, especially that a lot of those patients are young, they're usually without any known pulmonary disease, and the range of normalcy in the spirometry, at least, is quite wide. So, yeah. You know what I mean? And this is a restrictive lung disease, if at all. So do you suggest, is it cost effective to get a baseline so that we can compare them to themselves later on, should they develop whatever on their scans?
I definitely suggest to have baseline lung function, that's for sure, including the LCO, of course. In terms of a high-resolution CT scan, I think it's useful. You need to be prepared that in most of these patients you will find some abnormalities.
I'm talking about patients that have no symptoms.
Okay.
But at least you can use them to compare them in the future.
Even in patients with no symptoms. If you take a high-resolution CT scan, you need to be prepared that at least in a significant fraction of these patients you will find some abnormalities. Now, what you do with that? You take a lung biopsy, you move forward. So I think that if you are prepared to manage the results of these investigations, they need to be done. The starting point is crucially important, in particular for lung function, because you want to know if these patients deteriorate, in particular in the LCO. Now we get into the point of the LCO being variable, not reproducible, and so and on and on. But in the same center, taken by the same clinician, same technician, I think that in the end, it will be the most reliable and sensitive sign of lung involvement in patients with CTD.
A quick second question. You did show us clearly that connective tissue disease, say RA-related interstitial lung disease, they fare worse. And the treatment is a treatment of the rheumatoid problem.
Yeah.
So they fare worse because the ILD does not respond to
Yeah.
the usual RA, or because the treatment is not maybe, well, I don't know, robust enough or solid enough, or should we?
Actually, we don't know. So far we know that the treatment, the standard treatment for rheumatoid arthritis is not impacting on ILD, associated rheumatoid arthritis. I hope that in the future there will be trials addressing patients with ILD RA, but for the time being, I think that patient with interstitial lung disease and connective tissue disease associated is a huge challenge for us, because actually we don't know how to treat them. And we use the treatment with the standard treatment for the underlying disease. The point is that, as you have seen, it's not going to be effective. So there is clearly a medical need there, and I hope that future drug will address this population of patients. But so far, there is nothing that you can do.
Yeah, my question about also the same point. Like, most of these patients are already diagnosed with with connective tissue disease, and then after a few years they develop interstitial lung disease. So if they were referred to us and we diagnose them to have ILD and we want to treat them, they already received tons of steroids and they are already on immunosuppressive. So what else extra to add? And the question comes like about the new biologicals. Some of these biologicals have been used in sarcoidosis, ILD. So do you think the new biologicals of these connective tissue disease may be more helpful in connective tissue disease related ILD?
It's possible. You know, the so-called biological agents like the anti-TNF alpha agents in sarcoid, they have not been extremely successful. They did not resolve the problems. But I think that what is very clear from what we have, there is a need for new drugs, a new approach. So you are right that most of the patients coming to you as a pulmonologist with ILD, they have been treated with corticosteroids, cyclophosphamide, azathioprine, and so on and so on and so on. Again, these drugs have not been proved to be effective in these patients. So that's why we think as a community we should move forward and test new drugs in the properly assessment of placebo-controlled trials, because so far I think the treatment for these patients is not successful, is not enough.
In a patient who has a rheumatoid arthritis and he is treated by methotrexate, for example, how can you decide if the ILD is due to the medication or to the disease itself? Because if we stop the treatment and it's not the culprit, it will be dangerous for the patient.
What I do, if the treatment has been prescribed by the rheumatologist, I blame the rheumatologist. It's his fault and it's methotrexate-induced interstitial lung disease. But in reality, there is no way to assess that. What I can tell you, I had a few patients like that, and if a patient develops interstitial lung disease during methotrexate, that's already a good reason to stop methotrexate for two reasons. One, because methotrexate is not stopping from developing ILD, and secondly, because maybe methotrexate is inducing the ILD. So that's a good point for switching to a different drug. In order to be 100% sure if the drug has caused ILD or ILD is part of the rheumatoid arthritis, that's almost impossible, of course.
The response of the non-specific interstitial pneumonia due to a CTD or to the idiopathic, do you think there is any difference?
That's a very good question. So NSIP has been defined, again, as I told you, as a provisional category. So the non-specific interstitial pneumonia was anything not classifiable as UIP or as HP or as sarcoid. So it's just like, I don't know what it is, it's something else. That means that an SIP diagnosis applies to different entities. You can find NSIP, of course, in connective tissue disease and in idiopathic NSIP. My feeling is that the pathology classification in ILD is not definitive. So NSIP in connective tissue disease can really behave differently from an SIP in the idiopathic context in terms of response to therapy, in terms of prognosis, and in terms of what you see on clinical ground. So again, we are not like in lung cancer. In lung cancer, you get your pathologist telling you adenocarcinoma, that's it, done. No question. Maybe you can do molecular things, you can do hybridization, you can do polymorphism or mutation. But that's adenocarcinoma. When your pathologist tells you NSIP, it's just telling you something which is part of the information that you need. They need the information from radiology, from the clinical, from the history of the patient, and from the prognosis. That's why the new IIP classification is taking into consideration, into the classification, the 3-6 month behavior. So I think NSIP can be different in the context of connective tissue disease and idiopathic.
You think it's better when it's due to CTD?
As far as we know, any ILD associated with connective tissue disease has a better prognosis than any ILD with no known disorder, no cause. But that's just the, you know, it's a statistical evaluation from large cohorts retrospectively evaluated. So in general, patients with connective tissue disease and ILD, they behave better than patients with ILD and no cause of ILD. But that's very general. I don't think it can be applicable to the single patient.
Thank you again, Professor, for this rich discussion. Thank you all